when Webb asked me to give a talk, I guess like almost everybody is going talking about the diffusion model. So then instead of talking too much about diffusion, I'm thinking whether I can do something different. That I'm going to focus on a narrow topic, but something new, interesting, so that it can hopefully can inspire you to do similar work. The title is Image Generation and Intervention. And it's all done by my great postdoc, Shope, that's Shope. And I'm going to give the presentation, but please contact me or Shope if you have any questions. So I don't have anything to disclose. I think I can skip this slide, so everybody knows diffusion model. But I just want to mention one thing, that on the left, that shows the score function in very simple toy problems. So I encourage you always look at how the score function actually change over time, and it usually gives you a lot of insight of your problem. So the other model that we are going to use is called flow matching. So flow matching is basically a new model that you have a initial probability distribution and target probability distribution. You define the flow that is matched the target distribution. And doing this process is very much similar to diffusion model that you, for some samples, like X1, you define the trajectory. You can define different trajectory, and then the distribution along this trajectory. You use that as training data. You train a network that UT theta. Theta is the parameter of network to find the what is called the velocity field. And then for the new data, you basically use this to do the reverse process. You can get the distribution you want. So basically, this shows the loss function when you try to use this network to train a model that can predict a velocity during this flow, right? The difference between flow matching and the diffusion model is that diffusion model mostly is based on SDE, or in some case, people try to accelerate it and simplify it, use ODE. And if you look at this, mostly ODE is very similar. You can mathematically prove that it's almost the same as the flow matching doing the ODE diffusion. But flow matching has a lot of other flexibility. So when you, so both methods has disadvantage and advantage. For example, flow matching model, that is very fast. For a lot of application, you want faster application, and flexibility is a good choice. But the problem of flow model is that the distribution is generated usually is narrower than what's the diffusion model generate. And when you really care about out of distribution or long tail question, you need to be careful when you use flow matching. So almost nobody is doing general generation. Everybody uses condition to do conditional generation, particularly when you're talking about the inverse problem, right? So usually when you use conditions, the conditions are different modality, the raw data or other prior information you learn in other cases. So the purpose is always get better image. So what we try to do is that since the flow, all this generative model can generate an image that you didn't see, why not we use it for intervention? Basically, we try to predict future images. So if you give some intervention, what's the result where it looks like? By doing this, instead of improve the image, we try to get rid of the unnecessary scans. So that's the difference between here and most other conditional generation. So if you can do this, then you can optimize personal treatment using diffusion model or generative model. That's our purpose. I'm going to show two examples in this talk about how to do it and how it works, right? So the first example is an application that in the ICU. So ARDS is a disease, basically the lung start to collapse due to many reasons. COVID could be one major reason. Yeah, when this happens, basically the small lung element cannot open up and the air cannot get into, and the radiological phenotype is the aeration ratio in the lung. You can easily see it from the images. So usually in this case, you need to put a mechanical ventilator into the patient so that you use mechanical ventilator to help the patient's lung to open up and they have enough exchange of oxygen during this process, right? So in the ICU setting, there are different ways to think about this. Mechanical ventilator is helpful, but a study in New England Medicine a few years ago showing that if the patient is in a mechanical ventilator after 4 hours, there are more than 36% of chance that they will generate some kind of acute lung injury. And sometimes it could be very bad. So there's a huge group actually working on optimize the parameters of mechanical ventilator. So to do this, what they do is that one way is, if it's really important, they actually send the patient to do a CT scan and come back and use the CT scan to decide what's the parameter they use. It's very troublesome, considering all these patients are in the ICU and all kind of device attached to them. And sometimes you cannot even do the scan like too long. You have to, there will be 10 people standing in the room just for any emergency. The other way is that you can do it use X-ray, which is not optimal, or you can do it use ultrasound. Ultrasound actually use a lot in ICU. So what we try to do is that we try to check whether we can do this use diffusion model, whether we can generate 3D CT from 2D X-rays in the emergency room. Not only that, we also try to predict the image. If we change the mechanical ventilator parameters, what's the CT will looks like, right? This sounds like a very, very hard problem to solve. The key that we think that we can give it a try is that for all these patients, they usually have a CT before they get into the ICU. So we have a prior CT that we can use. We basically knows what this lung should look like, right, in a short time period. That's one. So we don't need actually generate the whole image. We can generate the residual of 2 images, basically the change, right? That's one. The second is that the parameters that you can change on the lung that are just few parameters. And if you have data that for the same lung that you change the parameters and you have a CT scan, then you can actually learn how this change. So there are 2 key points over here. One is that we estimate the residual instead of the whole image, like what's Dan said in the first day, that he also tried to estimate the residual instead of the whole images. The second one is that we want to change these parameters to optimize the outcome. So this is feasible because we are lucky to have a very good data set. These are the data set collected from my collaborator in critical care. So they have done a lot of images for these small pigs. And the whole experiment take like more than 1 day. So at the beginning, the pig is healthy. They create, they do CT scans, then they create like ARDS phenotype in real time. Then they change the parameters of the ventilator. And then every time they change the parameter, they do a new CT scan. So we have the image that is very easy for us to look at the residuals, right? And for the same peak, we're going to change the parameters and have the image associated with that parameter. So we take advantage of this, this data set and perform this study. So the training set is the residual of the CTs. Basically, we have the target CT and the prior CT. We calculate residuals, right? And for each condition, we actually take both the, both views, 0 degree and 90 degree. And we use these two plus ventilator parameters to do the training and also the testing. So the diffusion model, what we use is the network 3D unit. The method we use is EDM. EDM is a patch-based method that is good for CT, particularly high-resolution whole body CT, and because there is a positioning encoding in the method, so you can easily put all these patches together. There's not much inside of the innovation in the method itself. It's just fine-tuned vanilla EDM. So here shows that how can we do the training and inference. So then when we have this training network done, it is very important to evaluate for this kind of application, because at the beginning you will think it's impossible, right? If you really want to show it's possible, you need to use real data to do it. Fortunately, we have this data set. So what we do is that we use like the images to like quantitatively how good is the generated image. We also calculate the erosion rate of the lung, look at the host-field union inside the lung. And we also calculate total lung volume and see how this is compared with the ground truth. So for example, in this case, which shows that you add pressure to the lung, right? So the pressure from 3 centimeter water to 8 centimeter water. So in this case, on the left image shows that this is the input prior image that's before we introduce this animal model of ARDS. And on the center is the original CT after you change the parameters, right? I think this is, let's see, go back to one slide. Then on the right shows that the generated image. The generated image pretty much looks similar to the original CTs. And if you increase the pressure, then you can see this case that the lung is a little bit different, particularly lower part of the lung. And the generated image, again, is similar to original image. But if you look at quantitatively, okay, this slide shows basically compare with the generated image and the original image, what's the erosion ratio. The original lung basically has like 42% that the lung is closed. You can easily calculate this from original images. And then for the high pressure, this is pretty high pressure for from mechanical ventilator. The original lung is like 57, is 55%, and what we estimate is 57%. What's interesting is that, and the different pressure, if you look at these statistics, that when the pressure increases, that our methods start to introduce some bias in terms of the mean between the generated lung total volume and the original ground truth total lung volume. I think there are still some work that we should do for this case. We have some new method that we hope that can correct this problem. This is the first application I want to show. Basically, in this case, we generate the imaging given intervention so that we can show the image to the physician and they can, based on the generated image, make a decision. Then we don't need to do that image, or we do it in a simple way instead of do first CT in the emergency, in the ICU, which is really troublesome. We do a simple X-ray. Okay, so that's the first application. So we can think about a lot of applications like this in the ICU, in the emergency room. The second case I want to show is similar, but it's different in a way. In this case, is kidney cancer ablation. Basically, what you do is that you put a tube, right, inside the patients from the back, go to the kidney and inject some liquid that can freeze the cancer cells to death, right? This is a quite popular and very expensive procedures. It takes 4 to 5 hours, right, in a very busy interventional radiology room that has a big CT scanner over here and a lot of equipment to support this procedure. And what's really surprised me when I go to see it is that they do many CT during this process. I'm not going to say how many, it's just too much to me. And the procedure takes so long because you need to do the CT to check everything, right? I think for us, the imaging people in the room can think about a lot of ways to optimize this procedure. The one procedure that I'm particularly interested in to optimize is that when they insert the catheter and they make sure that it's in the right direction, right? You inject the liquid, and the liquid start to froze and generate something they call it ice ball. Basically, you froze the tissues, and you can see it from the CT that there's a shadow area, and this area grow over time. You don't want that area too big that damage the laboring tissues. You also want it cover the tumors, right? So they do multiple CTs during this process to manage it. So there are two things they can manage, right? One thing is that they could put like multiple catheters inside this location. That's one. The second is that how much liquid you put into that location, and between each sessions you can actually wait and see it and put more liquid. So these are the parameters that you can actually optimize. So the first thing we are doing, we didn't start to optimize these parameters yet. The first thing we try to do is that given the first CT at the time 0 that they do the injection, whether we can predict what the ice ball should look like during the next 10 minutes so that we can avoid multiple CT during this process. One, we can reduce the dose. I don't know how much they care about reducing dose since it's cancer patient. The second is that we can significantly reduce the procedure time that people really care about, okay? So again, what we have, the training data is at the CT at 3 minutes, 7 minutes, and 10 minutes. We also have the mask of the ice ball, as shown over here. This is like an image in this region that close to the ice ball at 3 minutes, 7 minutes. The mask can generate at 3 minutes and 7 minutes. Okay, and the network we use is 3D UNet, as everybody uses, and the method we use is flow matching in this case. Since I don't know when we use a generative model, we always implement both diffusion model and flow model. In some case, in this case, flow model gives you better result. So here shows that when you do the generation for different diffusion model, different parameters, the quantitative measurement about particularly the dice coefficient of the segment eyeball between the ground truth image and the generated images. It's pretty close, and it's actually close enough for our interventional radiologists think that the image is useful. We didn't do an observed study yet. We run the results through like a few interventional radiologists, and they like it, and they think that it can help to reduce the CT scans. There's one problem though. If you look at these images, because so once you have the flow model, right? Because once you generate this network, you can predict that the eyeball at a different time point. So we want to see how it's gradually changed and whether we can get a better result. And if you look at this, I think it's reasonable, but if you take a close look at it, is that it actually doesn't change that much. The reason is that we don't have intermediate step training data to train this model. So then what's the solution for that? Because I think this is a real patient, is not large animal, so we cannot get more training data to refine that network that predict the trajectory of the flow matching. So there's one work that we are doing right now. I want to mention this because it's aligned with many others that has talked about in this meeting, is that for anything that grow in biology and pathology, there are huge literature to model it using PDE, like the typical grow model that can grow and to model the growth of human cells or grow like cancers and so on. So what we try to do is that we build that PDE also in the flow matching, so that the whole process is not guided by the diffusion process, also is guided by the pathology, which is modeled by PDE. That's the work we are doing. Hopefully next time I can present that work. So in conclusion, that it looks like it's feasible to generate image given certain intervention. And once you have that, you can use it to optimize your decision without take more feature scans, okay? And but when you do this, you really need to be careful. Like you need to think about what's the prior information you can bring in, so that simplify your application. You also need to rigorously evaluate feasibility for different given application, particularly this is like a very year post problem. I want to introduce these two applications, my thinking about this application, so that hopefully inspire you guys to think about other applications follow the same type of pattern. The last slide I want to show is the whole group, and I particularly want to mention that Matt is in the audience. Matt did some really interesting work on hallucination and use deep neural network as observer. We don't have time to cover that, but if you guys are interested in this topic, please talk to Matt. That's all. I think I ran it very quickly and have a lot of time for questions.
Okay, quick question, very cool work. So in the end of your talk, you mentioned about using PDE to model the pathology pattern, like, spatial temporal pattern. Just try to further understand that. Do you mean the PDE is given, but you try to using a existing PDE, but to kind of learning all these parameters of the PDE? Or you were saying, from this data, you try to come up with a PDE to kind of, simulating what is happening?
So the PDE I mentioned is like some type of PDE for growth model that has parameters to be estimated.
Okay,
right?
got you.
So then I just put that there are multiple ways. So there are huge literature, it's called the PIN, physically informed neural network, that basically used as like a regularization terms.
Sure.
For diffusion model, we are thinking about a different way to implement that into the diffusion process of flow matching. That is like this iterative forward and backward procedures to do that, so that not only you say the data, for example, the ice ball should follow that pattern, and also be more could more accurate estimate parameters for that PD.
Okay, good. Thanks.
Yeah, it's a very, very nice work. Regarding the ARDS, you have a 50 peak data for training and testing. I'm just curious, because we also have lots of large animal data, but always hesitate to use animal data to training and test on human, or human data for training for animal. Just for large animal data sets, for people who have those, what's your general recommendation to how do we leverage human and animal data for kind of back and forth, or combine, or
that's a very good question. I remember you also use a combination of animal data and human data. That's a great question. Fortunately, our collaborator, Mozuzel, who just get a couple of NIH grants that apply to this same technology that he's working on to human data. So he's going to scan at least 10 human and a different condition. So we are thinking about a different way to combine the human data and animal data together, but once the result is done and we apply to human data, right? There are multiple ways to do it. One is that we don't need to like exactly match what type of group. We can get all the human data because there are a lot of human data and one condition, and do the CT scans, right? So we use that. We use animal data. We trying to do a flow matching that transfer the knowledge from animal data to human data. And then the way that we're going to regulate is that also test by the humans data with a different condition. That's one way. You need to be very careful to control a lot of parameters and ways on doing this. The other way is like what you have presented, that just simply combine these two data together to do the training. We're going to try both ways, but right now we didn't do it yet.
Thank you.
So I have a question on the first topic where you're looking at ventilated ICU patients. So I think it's a cool, interesting idea. I think there are probably a lot of challenges about mismatches between your prior CT and what actually happens with that X-ray imaging system. I mean, I can think of, motion, the techniques might be different, tables are different. Can you speak to a little bit about how you plan to work around all that variability?
Yeah, so that's a great question. If you look at the CT when patients have in the ICU, you see a lot of things in their body, right? And it's very different. So we don't use that CT for any training process. So the CT we try to get is like the CT that they did before they go to the ICU. So that CT, the prior CT, is relatively clean. But you're right that we need to be very careful, like which group of patients that we can use this technology, which group we cannot. So for example, even just for ARDS, some patients may dramatically collapse during like a very short period. If we think that the anatomy has changed significantly, we probably don't want to use this method. Or whether we can use other method to compensate that change, like use a rack, like bring more pride basically into this. And depending on as I said, this is not magic. It's basically you need to be very careful on which group you apply this technology, and you need to be careful on the evaluation too.
I think no more questions, so thank you, Quanzheng.
Thank you.